low power, this is 4x. So Simran, can you tell me what organ is this? Anybody?
Spleen.
Okay. Any other options? Any other guesses? Why did you say spleen? Let's just understand that. You may be right, you may be wrong, but if you've come up with spleen, then tell me why you're thinking of spleen. Okay, so you don't want to tell me why you're thinking of spleen. Okay, never mind. Now I'll tell you, basically we are dealing with an organ that has some sort of a fibrous capsule. If you can see over here on top. So you have a fibrous capsule, okay? Now, so you have an organ that A has a fibrous capsule on low power, and you have secondly an organ that is displaying various follicles. So these are all lymphoid follicles. Now, there are a few organs in the body that would be showing lymphoid follicles. One, obviously the spleen, as has rightly been pointed out by one of the students. The second is a lymph node, and the third would be the thymus. Okay, so we have to understand which organ are we talking about. Now, vis-a-vis the spleen, why did the students say spleen? Well, maybe because splenic histology is characterized by the presence of two components. One is the white pulp and one is the red pulp. So if you think that this is red pulp and this is the white pulp of lymphoid follicles, then you would be thinking that it's a spleen. But you have to understand that you are not in year 1 anymore, you're in year 2, where you're dealing with pathology and disease. So this is actually a photomicrograph of a section taken from it's not normal, from a lymph node. Now, the lymph node is basically because it has a lot of follicles. So you can see varying sized follicles over here with the mantle zone. So you have both primary as well as secondary lymphoid follicles. And if we recapitulate the histology of the normal lymph node, there's an outer cortex and an inner medulla, and you have the paracortical areas. Okay, so you can see a number of lymphoid follicles. So why is this not the spleen? Okay, so we go into higher power over here.
Ma'am,
Yeah.
can you use the cursor?
Okay, I'll try. Figure out, actually it's not working. Sorry, it's not working as of now, but I'll figure it out. Anyway, I think you can appreciate the fact that there are a number of lymphoid follicles over here, okay? इतना तो clear है कि there is an organ that has a fibrous capsule and it has varying sized lymphoid follicles, okay? Now, in the lymphoid follicles, had it been the spleen, you would have seen something else. And what is that something else? So in the lymphoid follicles, now you can see the various lymphocytes over here, but in the spleen, you would see a large eccentrically placed arteriole, okay? So that is missing in all the lymphoid follicles in this section. You're not getting it. You're just getting these collections of lymphocytes, okay? And this is the uniform story throughout. You can see minor arterioles, but it's nothing like the large eccentrically placed arteriole of the spleen. The second thing is that the spleen has something called the red pulp, which is a very, very congested area. Now, you may say this is the red pulp. No, it's not. It's a pathology. Now, what is that pathology is exactly what we're looking for. So, any guesses? What is this? What do you think this is?
Excuse me, ma'am. If you're still
Yes,
using pointer, we can't see it.
you can't see this. The entire screen is
No,
full of
we,
the pathology, my dear.
yes, ma'am. The
Oh, ma'am,
screen is
we are not able to see this.
You're not able to what? Yeah, yeah, tell me. Don't be afraid. I'm just saying that the pointer isn't working at the moment, so I can't help you with that. But I've focused the entire screen on the pathology I want you to understand. So what is this pink looking
Screen
stuff?
is and the
Yeah,
screen is, but the pointer, if you are using it, it is not visible.
I said I'm not using it because it's not working.
Okay, ma'am.
Can you, yes, can you tell me what this pink material is? Any guesses? I've focused it. It's right in the center. It's filling your entire screen. So what do you think this pink material is? Okay. Anyone else? Any other guesses? You've made a very good guess. Pink looking material could be amyloid. Any other guesses? This is another one. Just a sec.
apoptotic body.
Anyway, yeah, so someone said that there's apoptosis over here. So you're coming closer to what the actual pathology is. Anyone else? So we have
And
one
necrosis.
is fantastic. What's your name, Bacha? Who said necrosis deserves a chocolate? बता तो दो किसने necrosis बोला. Okay, so basically you have an eosinophilic deposition over here. Now, let me just go back to the lower part. So we start from the beginning. We have an organ. We have an H&E stain section. This organ has a fibrous capsule and you have various lymphoid follicles. So these are in various sizes and shapes. And then after moving downwards in the center of the section, you have a large area showing extensive deposition of some eosinophilic substance. Now, my question was then, what is this eosinophilic substance? Someone said amyloid, someone said it could be apoptosis, and someone then correctly pointed out that it is necrosis. So, what is necrosis? Necrosis is nothing but a form of cell injury or cell death, and it takes two predominant patterns. One is coagulative, where the outlines of the cells are still visible, and one is liquefactive, where basically the entire material or cell substance is liquefied. So these are the two major patterns that we see. However, there happens to be some other very significant patterns of necrosis. Now, the first option that came out was amyloid. So amyloid is an extracellular eosinophilic homogeneous substance, right? Glassy, eosinophilic, homogeneous. This is not homogeneous. If you look carefully, butters, you would even see some black dots within the substance of this material. It's not homogeneous, and it has some nuclear debris also. Okay, so this is reflective of necrosis. Had it been apoptosis, now apoptosis has something called as the apoptotic bodies. So in the apoptotic bodies, you would have basically well-defined rounded structures. Over here, everything is lost. Now that is primarily a feature of necrosis. Okay, now, another thing that I want to draw your attention to is that if you see carefully, now this is the boundary line between normal and abnormal. So, in the second lower half of the slide, we have necrosis, and in the upper half of the slide, we have the remnant lymphoid follicles. But something is definitely happening at the boundary. What is happening at the boundary? So at the boundary, we have, you see, this is the necrosis and this is the lymphoid area. What is happening in the area in between? I'm very sorry about the pointer thing. I'll correct it next time because unfortunately it's still not working. I'm trying. Now, I've just put it right in the center. So if you look carefully, there are some cells that are having elongated nuclei. Now, all these elongated, slightly serpentine looking nuclei are nothing but fibroblasts. Okay. So, whenever there is necrosis, in response to that necrosis, bounding, rather at the interface, you would see fibroblastic response. Now, the special thing about this is, if you look very carefully, it's pretty mathematical. So you have to just think about two or three things. First, you've seen an eosinophilic material. So rightly pointed out, is it amyloid? Is it not amyloid? Generally, amyloidosis in the lymph node is not a slide we're going to give to undergraduates. So an eosinophilic substance in the lymph node, are we going to give apoptosis in the lymph node? Again, no, that's a very tricky slide. So we generally give that to postgraduates. So eosinophilic substance, by and large, we're talking about necrosis. Now you have to tell us what necrosis is this. So first of all, necrosis in the lymph node. In India, the commonest cause of a necrotic lymph node would be tuberculosis. Now, if you look carefully, you have certain collections over here. Now, this is something that has not been taught to you in the lectures till now, but since I can see this and I want you to know and understand what is going on, I'm going to teach you this. So, this is the lymphoid area, right? Previously, I had shown you that in the interface, we had fibroblasts. Now, this is something new. So you can see that these are four kinds of cells or 4 or 5 kinds of cells in which the nuclei are arranged in the periphery like a necklace or like a wreath, or in our textbooks, it's classically described as a horseshoe arrangement. This is nothing but the Langerhans giant cell. And whenever you see this kind of cell, why is it a giant cell? Because it's much larger than the surrounding cells. You can see small dotted nuclei of lymphocytes. You can see a few fibroblasts. But these 4 or 5 cells are huge. So A, it's a giant cell. And there are various kinds of giant cells, and I'll ask you that in a later session, what are the types of giant cells. But at the moment, you can see giant cells that have a horseshoe arrangement of the nuclei. These are called as Langerhans giant cells, and once you see these giant cells, you should be thinking of tuberculosis. Now, a postgraduate entrance MCQ is Langerhans giant cells specific for tuberculosis? No, it's not specific for TB. It may also be seen in other conditions like sarcoidosis, but more commonly, it is associated with tuberculosis. So when you have this kind of picture, when you're seeing Langerhans giant cells, you're seeing caseous necrosis. So you're seeing this kind of necrosis. Now, why am I using the word caseous? So caseous necrosis means a cheesy quality. Now, you may be saying over here, what's so cheesy about this? I mean, there's nothing like cheese-like in this. But you're right, because the cheesy quality of necrosis is something that has been described on the gross, not on the microscopy. Over here, all you can see is amorphous, granular, inhomogeneous substance with necrotic or with scattered nuclear debris. It has a very, if you look carefully, it has a very uneven texture, it's not homogeneous. It's just so irregular, and you have these dots that are scattered around, which are like pinpoints. So this is characteristic of caseous tuberculosis, caseous necrosis, which is seen in tuberculosis. Now, is there any other thing that can help us make the diagnosis of tuberculosis? So over here, as I've just shown you, this is extensive caseous necrosis. So this entire area, which should have actually been filled up with lymphoid cells and, you know, the lymphoid sinuses and all that, it has actually all been replaced by extensive, irregular, uneven looking necrosis, right? And long-standing cases can even have deposition of osteoid or other things when the necrosis is very, very long-standing. So that's a different story altogether. And if you read up later on, you find that even amyloidosis is seen in tubercular lymph nodes, but that again is a very, very chronic story. So now there's another thing I want to tell you, and that is if you look over here. So in the center, now I'm going on high power, and this is all happening at the interface, mind you. So this is what is happening. Okay. So what is this? Again, one of those giant cells I was talking about. But at the same time, if you look carefully, this is some sort of a collection. It is a collection of histiocytes. It's a collection basically of something called as epithelioid cells. And if we go back into low power, you see, so I focus these. There's one in the center and one just left of center. So the one in the center has a lymphoid follicle above it. And the one to the left was the one I just showed you on high power. So these are nothing but accumulations of fibroblasts, of giant cells, of a few lymphocytes. And when they're accompanied with this extensive caseous necrosis, then the diagnosis is nothing and nothing but tuberculosis. There is one important point, children, I want to make to you, and that is caseous necrosis. Again, now that's an interesting point. Caseous necrosis in a lymph node may not be present in cases of TB. Sometimes you have to hunt for the caseous necrosis. So in this particular case, you can see that it's completely replaced by caseous necrosis. In gastrointestinal TB, for example, or in adrenal TB, for example, you sometimes even hunt for the caseous necrosis. So it's not an easy diagnosis. So the next question is, what do we do next? So now we've seen caseous necrosis. We know that it's a lymph node. We're seeing Langerhans giant cells. And, you know, by and large, we now are thinking on the lines of tuberculosis. So what next is that we can put up a special stain. So what is a special stain? We have to do something extra. We have to tell the clinician what is the reason behind this pathology. And the reason behind this pathology is now we're hunting for Mycobacterium bacilli. Okay. So we have to hunt for acid-fast bacilli. We have to hunt for the bacillus that is causing all this kind of a response. And we do that by putting up the ZN stain or the Zeal-Nielsen stain. So Zeal-Nielsen stain helps us to identify acid-fast mycobacterium, and they appear magenta colored. And that is how you pick up a definitive diagnosis of tubercular lymphadenitis. Otherwise, you just sign it out as granulomatous lymphadenitis. Once you put up an AFP and you see those magenta colored bacilli, then it becomes tubercular lymphadenitis. Definitive diagnostics, polymerase chain reaction. Okay, so there's PCR for TB. And so that, I think, more or less summarizes what I want you to know in this slide. Again, sorry for the pointer, but I'll figure it out next time. It's still not working. And over here, you can see that in between the lymphoid follicles, now this is the power of observation. Just look. So you can see that there are many lymphoid follicles, and in between, right on point center, you can see that there's this pink kind of thing. So this is nothing but a granuloma. It's nothing but that collection I was talking to you about. But in this collection, you might have a giant cell, you might not have a giant cell, but it's a collection that is standing out from the rest of the lymphoid follicles. So we go higher. So here we are, okay? So again, you can see that there are a number of histiocytes. So then you may ask me, where are the histiocytes? Like, I can't see the histiocytes. What are you talking about? So over here, can everyone hear me? Am I audible? Yeah, okay. So Jyoti, you can check your connection over there. Now over here on top, you have these blue dots, right? These are lymphocytes. Now you want to ask me, where are the histiocytes, right? So because I'm saying that these are a collection of lymphocytes now, of histiocytes. Now you have to understand, first of all, that there's a difference, in the color of what's happening. So on the upper side, all of these are lymphocytes. On the lower side, now you have this pinkish kind of material. So there's a little bit of necrosis actually that's going on. And then you have these nuclei that are not as blue as the ones on top, right? So some of them are opened up, some of them, kind of look as if they don't have anything inside them, right? So all of these are nothing but histiocytes. So all the nuclei that you can see in this particular area, they're not lymphocytes. The ones that are very dark, they are lymphocytes. But the ones that are opened up, they don't have any material inside them, and they're slightly lighter staining, they're all histiocytes, okay? So this is how you pick up a granuloma that is nothing but a response to an inciting agent, which in this case is Mycobacterium tuberculosis. Now we'll go back to low power. How did I pick this up? Lymphoid follicles, something is not normal. You can see this and you can make out that it's looking pinker than normal. It's not like a normal germinal center, right? Its size also is a little large, and it's not round, it's not regular, it's looking as if it's not behaving itself. And if you, with practice, you can kind of pick it up even at the lowest power. Okay. So now we go to slide number 2. I hope this was pretty clear. It's a very important slide, tuberculosis of the lymph node. Now, this is the second slide. Now,
Ma'am, please explain the previous slide. What was the pink thing which was looking like a germinal center?
okay, good, you're asking me, right? So, is this the one in the center you're talking about?
Yes, ma'am.
Okay. So this is exactly what I was trying to tell you. Now, if you look carefully, Bacha, the rest of the lymphoid follicles which are surrounding this pink kind of area, they all have some sort of regular structure. You have a germinal center and they are rimmed by a collar of lymphocytes. Okay, so there is some sort of order in their arrangement. However, the structure in the center that is pinkish looking is a granuloma, which is nothing but an aggregate of modified macrophages or histiocytes, which has developed in response to the mycobacterium tuberculosis bacillus, right? So it's different. If you look carefully, it is irregular, it is larger, and it doesn't have this well organized collar of lymphocytes. Okay, so just look at this. This is something that hasn't been taught to you, but since it's so evident in this slide, I had to talk to you about it. Look at this, right? So you may say, but this is also surrounded by lymphocytes. Sure, it is. I agree with you. But look at the kind of color you're getting in the rest of the lymphoid follicles. See, this one is a normal lymphoid follicle. This one is a normal lymphoid follicle. You have streaming collar of lymphocytes, right? The mantle. Look at this. Streaming collar, nice, well behaved, well educated collar of lymphocytes, right? So this is what you have. And then look at this. This is like some sort of, misfit. And then when you go on higher power, you see that, yeah, something is wrong. This is not the lymphocyte. It's a collection of histiocytes. Someone is trying to make a giant cell over here right in the center. And some of them are trying to secrete necrotic material also. So it's different. Okay. Now we come to the second slide. And okay, now tell me, what is this? So if we revise a normal histology, can anyone make a guess on what this is about? What is the organ that I've just focused?
Fallopian tube.
Absolutely perfect. Wonderful. What's your name?
Ma'am, Alvia.
Very good. Alvia, very good. So now
Thank you, ma'am.
we know. Yes, very good. At least you told me your name. Now the next thing is look at this. Let's just revise the normal. So we know that basically the fallopian tube lining is ciliated epithelium. Okay, ciliated epithelium. It's gonna be non-stratified. It's gonna be ciliated, or the tubal lining of epithelium, right? So this is tubal epithelium. And now you have to put your X-ray eyes on. So when you put your X-ray eyes on, you'd understand that if you look very, very carefully, there's a kind of fuzzy kind of border, and that is nothing but the villi, the microvilli. So over here, like I've put it right here at the center now. So you can see that this is sort of, I would have loved to use a pointer for this. Now you have a fuzzy kind of boundary of these plicating projections. These small, small things are nothing but microvilli, okay? So then you have, so the tubal lining epithelium, you have the secretory cells, okay? So secretory cells have an increased NC ratio, and you have something called as the intercalated cell, right? So this is nothing but the fallopian tube. This is the mucosal aspect, fallopian tube mucosa, and then we go on the outer aspect and you have the serosa, which is composed of adipose tissue, and you have all these holes in between. So what are these holes? They're nothing but blood vessels. These are all blood vessels which are distended with RBCs. Over here, you would even have some fallopian tube muscle, right? These are again blood vessels, and back to the fallopian tube mucosa. So this is the normal, right? Keeping that in mind, let's come here. So in the exam, especially for the postgraduates, I often tell them this, and now that it's come in an undergraduate slide, I'll tell you this also. Be very careful. For undergraduates, we're a little lenient. So what we do is that we generally focus the pathology and give it to you on a plate. So we tell you not to kind of shift the focus of the slide, because in exams, we want you to just see what we have focused for you so that you can make the diagnosis. But for postgraduates, it's very important for you to see that there are two sections on the slide. So one of them may be completely normal. Like in this case, we have a normal FT, normal fallopian tube. So you may say, oh, this is a normal fallopian tube. And you may miss out the pathology, which is actually in the second section, right? So what's happening in the second section? Now, I want to ask to you, what is this? What do you think this is? Yeah. Any guesses? Point center. Fat looking thing. What is this? There are some holes. Okay, I'll give you a hint. So the holes are the smaller blood vessels, the arterioles. But what is the fat looking thing at the center? Any guesses? You make any wild guesses also. What do you think it is? Okay, so this is actually a thickened blood vessel, okay? This is a thickened blood vessel. You can barely see the intima. The media is all thickened. Look at this one. Here you can see a lumen. And then you can see a thickened media. So why would the wall of a blood vessel become all thick like this? You can see. So these are all larger arteries, but they're all thickened. So obviously the patient may be elderly, right? And she may be having some hypertension. Okay. She may not even be that elderly, but yeah, she has thickened blood vessels. However, this is a secondary finding. The actual pathology is something else. So look at this. What do you think it is? Any guesses? What do you think this is? Let's go to the lower part now. So we had this section of fallopian tube mucosa, serosa, all this was all okay. We have the second section, which also has a bit of serosa, which has thickened blood vessels, but you have one weird looking area here. And then if you look down, you have another 2 or 3 of them here. I'm focusing, don't worry. It's okay. So what is this? So children, this is nothing but something called as a foreign body granuloma. Okay. So the earlier granulomas that I showed to you in the lymph node were granulomas that were composed of fibroblasts and modified macrophages and a few lymphocytes, a sprinkling of lymphocytes. Now, if you look at this is also a granuloma or a collection, but it's a collection in which you very frankly can't see any cells. Yes, I'm about to finish actually. Okay. So then over here, look at this. So what's inside the granuloma? Something inert, something that is not biological. It's not something that we've studied in normal histology in year one. It's something that is different. And this, children, is nothing but a foreign body. Okay? A foreign body means anything that is foreign or alien to the human body, which is coming from the outside world. So what is coming from the outside world over here? This is nothing but suture material. So this lady most likely had undergone some kind of operation of the genitourinary tract, right? She might have undergone a ligation, and that is to prevent further conception. And sometimes what happens is that when you're performing a surgery and you use your sutures basically to close the surgery or to do certain things. So nowadays, modern surgery has advanced a lot. So you have absorbable material. Sometimes the body isn't very good, it doesn't tolerate these kind of suture materials. So something or the other happens and the body isn't able to digest the foreign material and a response starts. So this is nothing but a foreign body granuloma. Neha, does this have a charger? It's anyway. Okay, fine. So over here, children, you can appreciate the fact that there are multiple granulomas with inert substance in the middle, and this is nothing but suture material. So this is the foreign body granuloma. At no place whatsoever in the section can I see any bit, can I see any focus of necrosis. There is absolutely no focus of necrosis. I can only see thickened blood vessels and I can see these 2 or 3 granulomas. So this is your slide, children, of foreign body granuloma, and this is occurring in the fallopian tube. Okay, so with that, I'll finish today's session. And I'll also convey to the team that next time we'll have the pointer in order so that the learning would be more joyous for you. If you have any doubts, you can get in touch with me. My name is Dr. Kavita, and you can ask your class representative. They can take my number, and I'm available on WhatsApp to address all your queries. Okay, so thank you so much, and hope you understood what's being taught. Okay, thank
Thank you, ma'am.
you. Yes. Oh, Bacha, in this granuloma, in the foreign body granuloma, there is no histiocyte. That's exactly what I was trying to tell you. This is an inert granuloma. Unfortunately, ना इसका charging खत्म होने वाला है. So I think ज़्यादा lighting अच्छी नहीं होगी. But yeah, but I'll just no till the time it doesn't die out, I'll show you. So look at this. So this is just a minute. Look at this. All of it is suture material. You can't see any hint of any cell over here. There are no lymphocytes. There are no lymphocytes. There's just this alien material, right? And these are actually, the staining is faded out. So if you look carefully, the thing in the center is called as a foreign body giant cell, right? So in a foreign body giant cell, unlike a Langerhans giant cell, you won't get very nice flower-like, wreath-like, or horseshoe arrangement. It's very calm, chill out types. So look at this. This is another foreign body giant cell. A few foreign body giant cells, right? Haphazard arrangement of nuclei. Unlike the Langerhans giant cell, where they were nice, decorative, slightly better. So this is what you have: foreign body giant cells, and you have this suture material, but Histiocytes are very infrequent. Most of it over here, you can see a little bit of histiocytes. यहाँ पे there's a giant cell, and to the left of the giant cell, जो 4-5 आपको nuclei दिख रहे हैं, these are all histiocytes. But by and large, you have inert looking suture material. Back to the suture material. This is the suture material. Inert looking, absolutely non-biological, coming into the area of the interface, arterioles, again, foreign body giant cells. Foreign body giant cell के आसपास you have a few histiocytes, and that's about it. I hope it's clear. ठीक है? Okay, बच्चों. Thank you. Okay.